We'll go back one slide just because we just kind of look at this chart for a second. So we talked about the ileuses last time, okay? Right, now we're moving into the obstructions. So most common cause of small bowel obstruction is going to be post-surgical adhesions, which we talked about. And then we're going to see how do we look at this on x-ray, right? So what do I need to know when I look at these small bowel obstruction things, if you remember? I know it's small bowel because I have the multiple loops kind of dilated on one another. And also I have my air fluid levels. How do I know I can trust my air fluid levels? I have an erect or standing or upright x-ray, right? Because if I didn't, then I shouldn't have air fluid levels because air rises and fluid sinks or falls, gravity, whatever you want to call it, right? So how do we tell the difference between an obstruction on it and an ileus is going to be more your symptomology, right? How is the patient presenting? What is your physical exam findings? And maybe some of that history, okay, when it comes to the small bowel. Here we go to compare the two. We're going to look at the timing on small bowels for ileus versus obstruction as well. When we go into the large bowel, right, this one's where it gets a little bit tricky. Understand that large bowel obstructions can cause abnormalities in the large and the small bowel. Why? Because when an obstruction is there, everything proximal to that is what starts dilating. Because you're still swallowing air, you're still drinking, you're still doing all that, and there's nothing that can get through. So when we have the large bowel obstruction, everything proximal is still dilating. If that goes back far enough and it gets to the ileocecal valve, it can then go into my small intestine as well. And I can have both of those that are dilated, okay? So the thing with large bowel is that it reabsorbs the remaining water, so usually we don't have any air fluid levels. That's another way you can tell the difference between large bowel versus small bowel. If it's upright, do I have air fluid levels? That's what I want to know. If I do, probably small bowel plus the valvular conaventes with the lines coming across. If I don't, possibly large bowel, plus when you go and you look at my large bowel, right, where's all of my, I'm going to draw them, they're not here. I'm showing you what you're looking for. Where's all of my many, many lines that come all the way across this? I don't have them. What I do have is some haustra here, here, right, here, kind of coming across a little bit, but not all the way across, and they're pretty well spaced out, okay? So that's how you can kind of tell large bowel versus small. Hey, it's also larger, right, but small bowel can be quite dilated. So, and I show that because if you trace this out, it's kind of like this weird kind of shape. It doesn't sit nice like I kind of told you that it doesn't when you see the pictures, right? So you can't really use the shape to determine it. You need to use really the valvular conaventes versus the haustra, and then kind of taking a look at the x-ray in that aspect as well. The small bowel will always have those valvular conaventes. But look at what the most common cause of large bowel obstruction is here. Cancer. Cancer, cancer, cancer. Most common cause. Frequently obstructs when it's in the left colon. So the left colon, also known as what? Okay, so rectosigmoid, right? Also descending, right? Either one of those I would accept in that aspect. Does that mean it can't be in the right side of the ascending colon? Does that mean it can't be? No, it does not, right? Frequently. So do not use left versus right side of the x-ray, or even when we look at some of the other stuff to kind of find cancer, to be like, hey, this can't possibly be a colon carcinoma because it's on the right side. It says it's on the left. Frequently, not always, right? We don't use never and always. We're going to show you something called an apple core lesion that we see when we do like those barium enemas that tell you, hey, this is probably colon cancer, and it doesn't matter what part of the large bowel it's in. Okay, so don't be like, oh, it's on the right, so it can't be that. Not true. Here are some other things that can cause it, right? Much like the small bowel obstruction, a lot of things can cause it. The most common is that colon cancer. Okay. So, what do I have here? I have a large bowel obstruction. Okay, and what you're going to see is something that looks. And remember how I said, X-rays, if they're upright, are going to tell you what on the film. Well, right. But what? And how do you know whether or not an X-ray is upright or not?
Correct.
It's going to say erect or upright or something like that. Does that say that on this film? It does not. So therefore, we can assume, dangerous word, supine, because that's the standard. If it's upright, I gotta write on it typically if it's upright. If I give you an upright film on the exam, it's gonna say upright, or standing, or erect, or something that is going to verbiage tell you this patient was standing, right? This patient is not lying down supine. The reason I show that on this one is because what does that look like?
Air fluid.
It looks like an air fluid level. Do we have fluid in the large bowel? Nope. Does this look like large bowel or small bowel to you? Large bowel. This is your transition point. This is where the colon cancer is. It's a giant soft tissue mass. This is where your obstruction is, we'll say. We'll call it an obstruction. Most common is colon cancer. We don't know it's cancer just off the x-ray. This is where your obstruction is. This is your transition point. This is where everything proximal is starting to dilate and everything distal is starting to collapse because there's no air or stool left in there, right? We don't have air fluid levels typically in the large bowel. This is your transition point. This is where the obstruction is. And so it's really easy for large bowel obstructions a lot of the times to be able to see where the obstruction actually is because you end up with that transition point. Do I have some small bowel dilated here? What do you think? I think so. If you look behind, right, I can see some of these valvular kind of ventes kind of coming over. So I think this is backed up to the small bowel, and then maybe some air fluid lines kind of sitting right down in here. So it's very possible that this also involves some small bowel too. But understand that it doesn't always have to. It just depends on if it's built up, pressure's built up enough to go past that ileocecal valve and start going to the small bowel. On your severe obstructions, a lot of times it will. Okay? So, yeah. Oh, thank you. On this side here, possible, right? This is my transition point. What I'm saying is like I see small bowel, is it air fluid levels? Maybe, I don't know. I'm using my valvular kind of ventes as my small bowel. So you can look for it. It can be, a lot of times it's not going to be there, right? And that's why I say I use this first. And I pointed this out because really what this one is the overlapping of the different types of bowel that are sitting right there. And it looks like an air fluid line. Maybe this, I don't know. It's hard to tell. So focus on kind of like your large intestine transition point in the house strap. We talked about the small bowel obstruction, post-surgical adhesions, right? That's the most common cause. Small bowel obstruction, post-surgical adhesions, months after. Large bowel obstruction, most common cause. Cancer until proven otherwise. Okay. Ileus, typically in the small bowel over the large bowel, right? We didn't really talk about large bowel ileus very much, did we? That's a small bowel issue most of the time. Most common cause of that, post-surgery. What's my time frame? Couple of days. Notice how the small bowel ileus and obstruction are both post-surgical. The difference is the obstruction is adhesions, which take months. It takes months. The post-surgical issue for the ileus is the inflammation, which is why it happens in a couple of days. But they're both post-surgical for the most common, for the small bowel. Okay? Don't get those swapped up. Most of your small bowel issues are going to have post-surgery. What's the time frame? What's going on? Other causes for small bowel thing, if it's not post-surgery, right? What are those organs that are close by the bowel that when they get inflamed and angry, they could cause this issue? The pancreas, the gallbladder, maybe the liver, right? Maybe the liver, but primarily pancreas and gallbladder. Why? Same reason as the post-surgical ileus. It's inflammation, it's painful, it hurts the peristalsis, so the small bowel says, I'm not doing it in this section because I'm tired of the pain, right? So, keep track of that kind of stuff. It's the inflammation on the ileus that typically causes the small bowel to stop peristalsing, and then know your physical exam findings. Yes, sir?
What's going to be your generalized ileus?
I want you to use your generalized or adynamic and your localized based off of your x-ray, not necessarily based off of cause, right? All ileiuses are some form of inflammation for your most common, whether it's generalized or localized. So typically, yes, your generalized and adynamic are going to be based off of those pancreatitis, cholecystitises, things like that. It doesn't mean you can't have one of those from post-operative inflammation as well. Typically, yes, but the picture will tell you 2 or 3 loops, right? A few loops for localized, or we saw some of those pictures where it's like, oh my gosh, it's like the entire small bowel. That's going to be your generalized or adynamic. All right, questions on the intestines? Okay, esophagus. There it is. Okay, it's a tube, swallows it. Look at it. There's not a whole lot here, right? It's a tube that peristalse that brings food from our mouth down to our stomach. So we're going to look at different abnormalities on here, okay, and things that you can find. We're going to go over some of those. So a single or barium swallow study or double contrast barium and air, right? These are studies that we can do. Video esophagography. Ooh, say that. Study of choice if you're concerned about aspiration. We briefly talked about this. A barium swallow is literally drinking the barium and just taking x-rays. Okay? Take a couple of x-rays and that's it. Just trying to highlight the esophagus so we can see if there's any structural abnormalities going on in there. When patients are having issues with aspiration, kind of we briefly talked about it before, when they have issues with aspiration, what are we concerned that could be malfunctioning inside? What anatomy part? The epiglottis, right? Is it completely closing off the trachea like it's supposed to? What's going on? So, in order to do that, we take videos, right? We do that fluoroscopy. And we do the same thing. They're still drinking barium. They're still swallowing barium, right? But a video esophagography is different than a barium swallow. A barium swallow is the patient is swallowing the liquid barium while we're just taking regular x-rays to just look at the structure of the esophagus. To look for things like ulcers or diverticuli, things we're going to look at here. The video esophagography is somebody who's aspirating, and they still call it sometimes a swallow study in the clinic, right? But what you're doing is you're now using the fluoroscopy and you're watching them swallow stuff, right? So you're going to watch them, or they're going to watch them swallow the liquid barium. Watch the epiglottis come down. Watch the stuff go into the esophagus, make sure none goes in the trachea. That works well, great. I got some powdered barium. I'm going to mix it in some pudding. Feed the patient that. The patient's then going to eat the pudding, a little bit more solid than liquid. Swallow it, watch it go down. Then they're going to get a barium pill, and they're going to swallow that with water and watch it and see if the pill goes down to figure out if liquid, chewed food, basically, that's what the pudding is supposed to do consistency-wise, and solid, how long does it get past the epiglottis, and is there anything that's causing the aspiration? They will still take spot films, and we talked about like pictures as they're going through, but really they're recording and watching the video of the patient swallowing these different things to see what's causing the aspiration. Is it a structural issue with the epiglottis or not? And that's what the video esophagography and this fluoroscopic observation, that's what that means. That's kind of the description of that, okay? All right, so here is one of the pictures of a normal study of the esophagus, okay? So smooth edges all the way down. Don't get so hung up on the shape because it can be different depending on the view, except for the fact that it should be this nice, smooth, tubular structure full of barium. Now, you might see that we have a lack of barium in that area, and I'm telling you this is a normal study. Why is that? What does the esophagus do? Squeezes, it peristalses, right? So when I squeeze the barium down, and if I take a shot right as it happens to open back up, there's going to be a little bit less density there because I just pushed it out and I'm waiting for it to get coated again. So there's multiple pictures and multiple x-rays that happen with this exam. This is just one example, okay? So you're looking for the nice smooth edges, the nice tubular kind of structure coming all the way down here, highlighted with the barium. Dilation, this one, not a great photo of it, because you're like, well, what the heck is this? How do I know that's esophagus? You don't. But when I take a look at this one, right, again, comparing normal size esophagus, normal size, and most people it's going to be right around that size, versus widened esophagus, okay? This is a dilation of the esophagus. Now what's happening on this particular one is the lower esophageal sphincter isn't relaxing, which means it's not letting the barium go into the stomach, and so it's backing up, causing the esophagus to dilate, okay? That's not always what causes dilation, that's just in this picture, okay? So that sphincter's not opening, releasing it into the stomach, and so, I mean, you're getting a little bit of trickle, and you can just kind of see like a little bit of it right there trickling in. But everything's just kind of backing up, causing dilation of the esophagus. Okay. Constriction. So notice how this is not constriction, it's completely closed off, causing dilation of the esophagus. Notice how on the constriction, the esophagus is tubular, it's smooth, it looks like it's supposed to. It's not super dilated. What's happening here is it's slightly constricted. In this particular case, you have a hiatal hernia. And so what happened is this is all part of the stomach, and this is my diaphragm. It is projected up through the diaphragm. All right, that's a hiatal hernia. So what you're looking at here is a constriction. This should be down at the transition point of the stomach. And it's really not anymore because I have a hiatal hernia happening. So why is it constricted? Because I have my tubular structure and it comes in like this. And it's just a definition of constricted. Yes, there's also a hiatal hernia there. But if we're talking just esophagus, this is what constriction is. Not this. This is dilation. Notice the size of the esophagus is different. Yes, some would be like, well, it's because the sphincter is constricted there, it's not getting through. Well, no, but that's a problem with the sphincter. The esophagus doesn't have that constriction in there. The esophagus is just dilated. Here, the esophagus is constricted. Okay. That's called the Schatzki's ring. Okay? Pathogenomic for things. That's a good board thing they like to throw out there at you. Right? If you see Schatzki ring in a report or something along those lines, or anything yet, you start thinking hiatal hernia, you'll learn more about hiatal hernias in GI, but that's a good thing to start thinking when you start to see that name, because that's what that's called. Okay? So, this is really one of the only ones. Oh, yeah. What's up? I don't care. He was raising his hand for you because he's a good soldier. Schatzki, say it right. No, I'm just kidding. Go ahead. What's up? I don't know with this particular picture. If I was looking at just the image and I had a guess, I would say this is probably a sliding one, but I don't know for sure. I think it's either or. Yeah, I'm pretty sure it's either or. Because the concept of it is that it has shifted up into there, so you can see that ring now because the stomach has just been coming up into the chest cavity. That's what I'm looking for. So I think it's either or. All right, this is the only other picture I have of a hiatal hernia. This is the stomach. Here's my diaphragm, at least it's supposed to be there. We'll assume it's somewhere here. But the whole stomach came up, and then this is my air fluid level from my stomach. So these things can get pretty nasty depending on how bad they are. Usually when they're this bad, it's usually trauma, right? And then it's not something, this isn't something like slowly happened. Sometimes the hiatal hernias can be very mild, like the other one that we've seen, causes some indigestion, causes a sense of early satiety, right, fullness, because the stomach is kind of sitting up there. But this is usually trauma. The whole stomach has come up through the diaphragm, and they are going to be surgerized to fix it. Okay. Esophageal cancer. If you ever find a patient with this is bad news. It's not very common in the United States. Why is it not very common in the United States? Because we have good preventative health care when the patients actually go. It's more common in areas, do I have it on here? No, more common in Asia. Okay, esophageal, so for example, a scope. Anybody who has reflux, right? If you have heartburn and reflux and you're on medicine, right? If you need medicine for more than 5 years, you should get a scope, EGD, right? Esophagoduodenoscopy, to go down and look and make sure you're not having what's called Barrett's esophagus or any kind of changes in that esophagus, because that can lead to cancer. Anybody who's for more than 5 years should get one of these at least once. Usually it's a one-time thing, but you should get one. Because what causes that a lot of the times, you'll learn it more in maybe ENT, maybe GI, is because of the constant irritation of the stomach acid in the bottom of the esophagus. Body doesn't like irritation, body changes. Instead of causing an ileus, which isn't a thing in the esophagus, it decides to change the type of cells at the bottom of the esophagus to make it less irritating. Those cells in that change, they continue to change and they end up becoming cancerous. Now, because we have the preventative stuff in the US and we have pretty good treatments for our reflux, we don't see it very often. Over in Asia, with all their spicy foods and the way that their diet is, and not having that kind of preventative health care, this is actually more common esophageal cancer in the Southeast Asian type areas. So if you're deployed over there, stationed over there, this could pop up on your differential for sure. The catch with these things is because they're super asymptomatic until, guess what you can't do? Swallow, right? So my father-in-law's brother, before we moved my father-in-law in with us, ended up with esophageal cancer. He had heartburn for years, never went in. By the time he finally went in when he couldn't eat or drink because it hurt so bad, they couldn't even get a pediatric French tube down his esophagus to try to get a feeding tube in him. That's how small his esophageal opening was. And it was stage 4 esophageal cancer. It's kind of like pancreatic cancer because it sits asymptomatic for so long. By the time you find it, usually it's metastasizing other places. And that's really why it has a poor prognosis. It's not so much about the esophageal cancer itself. It's the fact that by the time you find it, over half of them have already metastasized somewhere else. And that's the issue with it, right? So, anyways, if you are concerned about esophageal carcinomas, barium esophagograms or barium swallows, that first thing we talked about, is frequently the initial study, and usually the symptom is going to be simple dysphagia. It hurts to swallow. They're probably going to be a smoker, or was a smoker at some point, and or long-standing history of some type of reflux disorder or something along those lines. Those are your 2 top factors of something along that. Be concerned about this. There's the different ways it could look: constriction, polypoid mass, irregular wall, small ulcerations. It's all of those things with the history and the dysphagia that make you start thinking esophageal cancer. So here are some of the different ways it's going to look. And you're like, how do I know this is cancer? You don't off of just the image, right? You don't off of just the image. You have concerns of it based off of the patient history, based off of the image together, okay? So this guy is constricted, okay? This is missing here. And then this one's kind of coming down again. So all the normals we've seen have typically been this nice, smooth tube coming down. So anything that causes the tube to not be smooth is concerning. Okay? Can I call this constriction? I sure can. If I'm concerned about it, I'm like, what's going on with it? If I have that patient history and stuff, I might be concerned about esophageal carcinoma. Okay? Can I call this a filling defect, right? We last talked about the peristalsing, right? How do I know that's a defect or some mass or something and not the peristalsis thing? I don't have the smooth edge on each side before. If you notice on the normal, go back and look at that one if you have it available. When I look at my normal, I can still trace out my smooth edge. See the edge of the esophagus right here. The edge isn't what's missing. The edge is there. It's the inside that has a small filling defect because of the peristalsis. When I come back to this one, where's my edge? It just stops, right? I can't trace my smooth esophageal edge down there. So that's not a peristalsis issue. That is a mass that is obstructing the area of the esophagus. Here I can, but I can't do it on both sides, okay? So, and then this is just another one just kind of carved out there, just showing you different examples of this. Now these studies are really good, but what do you think the most common complication of these studies are? Aspiration. Aspiration. So what's highlighted here? This is the bronchial tree, right? How the heck does this happen? Drink, drink, drink. Boom, just inhaled a bunch of barium because they're consistently drinking this stuff while you're taking the pictures, right? It's like, it's actually close to a bottle about this big, right? So it's about yay big, it's about yay big around, it's a powder, they mix it with water, and then just drink. So they start coughing or have a sneeze or some kind of coughing fit, this is what happens. This is one of the few times I would say serial chest x-ray monitoring would be a good idea. Because barium is not water soluble. This is going to take a minute to go away, and the odds are it's probably going to lead to an aspiration pneumonia. right? So be ready to treat that. Do you need to do it right away? Not right out the get-go, if they're not having any of those symptoms yet, because maybe they won't get an aspiration pneumonia, but they're probably going to in that aspect. Diverticula, outpouching. Outpouching of the esophagus. Anywhere in here is an outpouching. This one is more straight on, right, which is why it's sitting like that. So what happens, this is after the barium swallow study. You drank all the barium, it's not in the esophagus anymore, but some of it got into the little pouch, the little diverticula sitting right there. The Zankers is the one you're gonna learn about, right? But it sits right in there, and so the barium's just sitting there because they drank it down, someone in there, the rest of the peristaltic stopped and sat in there. This is common in patients that are saying, yeah, it's really weird, like I'll eat, and one of two things. Either got really bad breath again because the food's just sitting in that diverticula rotting away in the esophagus, or like I feel like I always have something stuck, like right here, and I can drink a whole glass of water and stuff, it just doesn't clear. I just feel like I always have a piece of food or something stuck. Or sometimes I go out and I eat my steak, and we have dinner at like 6 o'clock at night, and then at like 9 or 9:30, like I cough, I chug up a piece of meat, right? Because it didn't make its way down into the stomach. And so they actually squeeze it, actually able to get it out, and they actually have a chunk of food from like hours before. So these are some of the things that they're gonna come to you about and make you go, huh, maybe I should get a barium swallow study, because the odds are, or a video esophagography, because the odds are that they may have a diverticula there. Now, in this case, I would probably start with the barium swallow study because you don't know they have a diverticula yet. Remember that barium swallow is just looking at the structure of the esophagus. And then after you get this, depending how big it is, then you may be more curious on, is that affecting liquids, solids, right? Chewed food? I don't know yet. Let's go take that next step and do that study of choice. Right. Ulcerations. Know that it's a possibility, right? I'm not too hung up on ulcerations in the esophagus. It is an abnormality because I'm like, hey guys, look at the ulcer here. You're like, what? Right? So the key thing on some of this is you can look at how the rest of the esophagus, how the barium is kind of sitting where it needs to be, and just look at the pattern of it. And then I have kind of like this circle, kind of like this little dot here in the center. I'm going to circle it again. It's more here, and kind of like that little filling dot in the center there. That's kind of what my ulcer is. You can kind of see on the line, it's not necessarily smooth, it's kind of hazy and kind of a little polka dotty and choppy there. That's going to be my ulceration. Just know that ulcerations of the esophagus, although rare, is a possibility. The radiologist is going to pull that out more than I would expect you guys to, but it's one of the abnormalities that's there. And then we have perforation. Okay, what's the difference between this and the diverticula? Right? Yep, kind of heard it throughout the class, right? Smooth edges, regular edges contained versus kind of hazy and kind of fuzzy around the outside, right? I don't have this nice containment here. I got some that's here, some that's here, kind of comes in here. It's a fuzzy edge, right? It's not this nice, smooth edge that kind of comes around. That's the difference between your perforation and your diverticula, okay? That's the difference between your perforation and your diverticula, is the smooth edge versus the not smooth edge. Right? So we got another constriction or stricture coming down. Look how thin it gets. I can't really tell you if this is a hiatal hernia on this one yet because of the fact that this is like an oblique view. If you kind of look at like how the ribs are and everything, it's this weird oblique view. So like, where's the diaphragm? I don't know. But I can definitely tell you this is an esophageal sphincter or stricture or constriction because look at how small it gets down there towards the end. And then here I gave you a slide of both the diverticula and the perforation together. So you kind of get an idea of how to tell the difference between the two. Okay? Clear borders versus unclear borders. So way back to last week. Whew. What's going on in this one?
Fluid under the diaphragm.
I know, right? Generalized information.
Fluid under the diaphragm.
We got right there. So, pneumoperitoneum. Couple of ways I can be confident it's a peritoneum and not necessarily the mediastinum, right? I don't have my continuous diaphragm sign here, but I definitely have air below the diaphragm on this one here. And then normally you can't always see it by the stomach, but this one we can. This one we can see quite nicely, right there behind the heart. So that is a pneumoperitoneum. Why? Probably some kind of perforation. Where? I don't know. In the abdomen. Could be small bowel, could be large bowel. I don't know where. What do we call that guy again? Diverticula. All right. Okay. Stomach. We're going to look at the same concepts in the stomach. Okay. There's the stomach. Look at all my root A. Good times. Same concepts. We're going to look at all the same things. We're looking at edema, dilation, ulceration, and perforation. In the stomach, though, when I'm trying to evaluate the stomach, not just the esophagus, but the stomach, I do my upper GI endoscopy, or the esophagogastroduodenoscopy. We just say EGD because we don't like to say big words, right? An EGD. What is that? It's a camera that goes in down the throat, takes a look at the stomach, and goes all the way into the duodenum just a little bit. This is wonderful for looking for any type of ulcers, right? Looking for any kind of ulcers, looking for any potential perforations. You can also evaluate that esophagus like we talked about to look for the invariant esophagus because you're going past it anyways. So you get some good pictures of looking at that. Okay? So this is going to be your study of choice. That's why it's in blue there. For if you're concerned about your peptic ulcer disease or if you're trying to evaluate for hematoemesis, which is blood in the vomit. Why? If I have peptic ulcer disease or blood in my or blood in the vomit or hematoemesis, right? What is on the top of my differential that I'm concerned about? H. pylori, okay, H. pylori is true, but that would be the cause of the ulcers, right? My scope is not going to do that. My scope's not going to show me that. And it says it largely replaces the barium swallow. Why is it replacing the barium swallow? What am I worried about? Perforation. What is barium? A non-water soluble contrast. That's what we give in these studies. So if you have the concern of a possible perforation, peptic ulcer disease, or I'm throwing out blood, which means I probably have a bleeding ulcer, which could also be perforated, that's why we've gone to these scopes as opposed to doing the barium swallow. Now, if you're not concerned for perforation, you're not screaming peptic ulcer disease or hematoemesis or anything like that, and that's not part of what your differential really is high up, and you're just trying to evaluate the stomach, then your barium swallow is going to be just fine because they're going to drink the barium, you're going to take pictures of the stomach as well as pictures of the esophagus. Okay? So, but the EGD is for anything when you're concerned about a possible perforation. Okay. Sorry, I thought I was going to do the other thing. Yeah. Yeah, I would prefer not to. That was where they didn't suspect it, basically. So when you see the perforation on the esophagus here, this was them doing a barium swallow, not expecting or seeing a perforation, and boom, there it was. Okay. Perforations in the esophagus are not very common. They're very hard to do. So honestly, I can't think of a situation outside of something you're going to learn about, like Borhavi syndrome, where they're like constant retching, vomiting over and over and over and over again, and now all of a sudden there's blood. Then maybe I'm concerned about like those Mallory-Weiss tears, and for those of you who don't know if that's ENT or GI again, where you get it, but concerned about that. But in the absence of a patient coming in with that kind of a history, I'm rarely ever concerned about this. So this was not expected, and it was found. Yeah. Okay. Here's what a normal study looks like. Okay. Why do I have pooling here? What area of the stomach is that? Go back to anatomy. What's that area of the stomach called?
Fundus.
Fundus. Ring a bell, phase one, we're in phase one. Freshman semester, A and P, right? But if you think about the way the stomach sits, right? These patients are lying supine, and the stomach kind of sits back, and so the fundus is more posterior than the main body of your stomach. So when you have that barium in there, it actually will pool down into the fundus. That's actually normal to have a little bit of pooling here. and some pooling kind of sitting here in the pyloric area when it kind of goes around. Why? Again, because that's where the pyloric sphincter is before it goes into the small intestine, so that's got to wait for it to open up. But the rest of this is all just your normal rugae. So I want you to focus on the thickness of the rugae, kind of what it looks like, how frequent they are, kind of where they sit around. This is just the folds of the stomach, and the barium basically sits in between those folds in that area. Then when you go into edema, you end up with thickened rugae. So again, pyloric area, fundus, normal to have pooled barium in that area. That is normal. That does not concern me. But when I'm looking at my rugae, look at how much thicker they are. Right? I got thicker kind of rugae all sitting around in here compared to nice, thin, uniform. So I have these thickened molds, or folds, not molds, mucosal folds, showing edema or inflammation from this patient who has gastritis. Now, are we going to do a whole lot for this gastritis? Not really, right? But this is the study that you show. You basically would get this study, patients having a lot of stomach issues, you're not concerned about a perforation, you say you order this study, and you look at it, now you at least have an answer for the patient. You're like, yeah, there's no masses in there, anything crazy, but you do have some thickened, you have some edema, which goes along with the gastritis that we thought you had, so we just gotta kind of let this self-resolve in that aspect. Dilation. Right? The nice part about dilation of the stomach is it's usually due to air. Okay? How old is this patient? Just give me a general age group. Pediatrics. Why do we think this is more common in pediatrics than adults? Anybody think why? They're swallowing all this air. Feeding, right? Especially bottle feeding, nipple feeding, doesn't really matter. If they don't get a good latch on either the nipple or the bottle, whatever they're eating, they're swallowing a lot of air. A lot of air. Sometimes this can cause, everybody calls like colic. When you have like a colicky baby, a lot of times it's due to the indigestion of the dairy, if they're not drinking breast milk, the formula they're taking can cause this, but sometimes it's also just air built up in the stomach. The stomach is dilated, it's painful because they swallowed so much air while they're feeding due to a poor latch on either the bottle nipple or moms, right? And so more common in peds, the stomach air, right? It's not the stomach, yeah, sure, it doesn't usually cross midline, but hey, in pediatrics, everything's kind of smushed together, right? So maybe it will, but what we've learned is the gastric bubble. We've learned about that, we've seen where that's at. That definitely does not usually cross midline. And this is just a bunch of air in the stomach, okay? Now we talk about ulcers in the stomach. There are two ways to kind of see ulcers in the stomach. This is one of them, and it's all going to be positional. Notice how, when we looked at our rugae before, our normal, right, everything just kind of folds in, it goes down, it comes around, it does the shape of the stomach in that aspect. Here, we have pooling. All of the barium is pooling towards something, right? That's your ulcer. Think whirlpools. Think out in the ocean, whirlpools, right? The old cartoons when we were kids, the little pirates would get out of the whirlpool, the water swirling around going to the center. That's what happens with the barium when you end up having an ulcer. Instead of having the normal folds, normal rugae just going through it, everything is aimed towards this divot, and this ulcer is sitting in there. So you start to see the barium kind of pool in this kind of a picture and kind of a setting. This is one way, okay, to see an ulcer. Another way to see an ulcer is that when you get pictures to where the entire stomach, they've given them so much barium, the entire stomach is coated. I don't have any rugae here, okay? But I have look at all this barium. That's way more barium than we've seen. So they drank more barium, probably because they're getting ready to do what's called a small bowel follow-through, which is basically an evaluation of the small bowel. And so they make them drink a lot of the barium because they got to get it to go through all of that intestine. And they take pictures of that. So you drink more barium because just a little bit for the esophagus, the barium swallow is not going to be enough once it spreads out in the entire small bowel. So you get some of these more filled stomachs, and then when you get the picture, you're like, well, that's so much barium in there, the whole thing should look like this. But now I have these filling defects. Those are my ulcerated areas of the stomach. Get those filling defects in there, okay? All right. Most ulcers are benign, most ulcers will heal, there's a small percentage that will represent malignancies. Alright, don't get so much on the numbers, I'm not a big numbers guy, especially for this stuff. It's more just letting you know how often are you concerned about something, okay? Top line really important, because if you don't remember that H. pylori accounts for the majority of gastric ulcers, then you won't know to test for it or treat for it. Okay? NSAIDs, sure, in our population, probably, right? Right? We're trying to get away from the whole vitamin M thing. Those of you who recently saw your PCM probably won't agree with me, but we are trying to get away with it. Get away from it as much as possible, right? Which is why, for those of you that'll have me in ClinCore, we'll talk about ibuprofen, you'll talk about what the max dose is, right? But then like what we tell patients the max dose is, because they always take more than what you tell them to. But that's some ulcer stuff there, NSAIDs and H. pylori. Here's a duodenal ulcer, right? So this is now why that scope kind of goes past sometimes and goes into the duodenum. So same concept. I have the duodenum here, that's what this is. This is after the stomach, and I end up having an ulcer sitting on the outer wall of the duodenum, and the barium is pooling right in there. It's coming in and causing a pool, okay? Now, duodenal ulcers are best going to be seen with CT just because it just is more detail and depending where the duodenum sits. It can be hard to get this kind of a picture, to be honest, because one of the better pictures I've seen, which is why I threw it in there for a duodenal ulcer, because they can be really hard to find on X-ray. But CT will help you visualize that a little bit more. And when we're concerned about ulcers, we get concerned about perforation, and usually this is the first time you're going to see it. So this is just kind of bringing it all back, right? Those ulcers perforate, we cause a pneumoperitoneum. Pneumoperitoneum makes you go, okay, what perforated and what's going on? Okay, in this case, this particular patient, it was a stomach ulcer that perforated, causing air in the abdomen. Can't know that by the picture, but I'm just letting you know. All right, so what are those arrows pointing to based off of this? So here's the body of the stomach. Fundus is up here, antrum and pyloric area, so that's going into the duodenum. So then what do we got there? Duodenal ulcer, right? So we can see some of these sometimes, especially in this case when the majority of the barium has moved on, but I still have just a little bit sitting right there. So that's another picture of a duodenal ulcer. I know it's duodenum because again, here's my antrum and pylorus of the stomach, so that this is going to be small intestine. What do we call that one? Air in the stomach, but also dilation. Right? Dilation, look, it's another peds. This is very rarely happens in adults. Very rarely happens in adults. Okay. What do we got going on in the primary thing in this one that stands out? Pneumoperitoneum. Yes, there's a lot of other stuff going on in here, right? But like I'm rotated, so this gives me questions because this is a patient who's in a hospital bed. But definitely a pneumoperitoneum stands out. Now, what's going on here? A couple of key things that help you understand what the abnormality is here. First, what's that? Chest tube, okay? See a little hole right here? That's that chest tube. It's got that radial opaque line on the tube so that way you can see and make sure it's all the way in the chest. Then, what's that say? Supine. We don't often do supine chest x-rays, which is why it has to be labeled, because if it didn't, you wouldn't know. So now you know I have a chest tube, you know it's a supine chest x-ray. What's the next thing I'm looking for to see if it's there? Going way back. Okay, so what's the difference between right and left claustrophrenic angle on that? Are they the same? Are they fairly equal? What do we call this? All right, let's take a step back. If I have a chest tube, what conditions am I thinking they had? A pneumo or a hemothorax, right, or a hydrothorax or something along those lines, either one. Do I see that on this x-ray? Why not? The chest tube did its job, right? So great. So chest tube is clue 1. Now my question becomes, can I distinguish on this x-ray, right, I know I'm playing guess what I'm thinking, can I distinguish on this x-ray from this chest tube and this picture whether they put this chest tube in due to a pneumothorax or due to a hemo or hydrothorax? Yes or no? What is it about the costophonic angles that give me a really good, confident answer? I could have drained all the fluid. Chest tube could have taken all the fluid out. I'm going to tell you this was a pneumothorax. Why? Supine chest x-ray, deep sulcus sign. Remember back to the pneumothorax lecture. Bringing it back. I know it's been a couple of weeks, right? We talked about that deep sulcus sign, specifically in supine x-rays with patients who had pneumothorax. That's what's going on with this costophrenic angle here on the right. That is the deep sulcus sign, compared to the left costophrenic angle, which is where it's supposed to be. So, a couple of different clues on that. The chest tube, absolutely, you're right, tells you pneumothorax or hydro/hemothorax or both, I don't know. But with my deep sulcus sign, I can be confident it was a pneumothorax, and only because I was told this chest x-ray was supine. Because this is a supine chest x-ray finding. You remember that? I know it was a while ago. Trying to bring it back. Okay. All right, just a couple more review slides and we'll get you on a break. Okay. So the difference between this here, not really different, this is showing you supine and upright of a small bowel obstruction with dilation. Okay? There is no way you can tell me based off adjusted pictures if this is an obstruction or this is an ileus. You need the patient presentation and the physical exam findings because they look exactly the same on x-ray, right? You might be able to turn around and go, well, let's look distally, right? Well, guess what? Look, I still got some air down here. I got a little bit of air. Maybe you caught it early on, right? And so with the small bowel, I need to give you hyperactive, hypoactive, or maybe I don't give you that. I give you the history. Surgery 36 hours ago, surgery 6 months ago, 5 months ago, 8 months ago, something along those lines to help you distinguish between ileus or obstruction. Pneumoperitoneum, showing you what it looks like on CT. It's all my air up against the wall of the abdomen. Shouldn't be there. It should be nice and contained in the bowel, like right there. Right? And so when this is more air in between the organs, that's not nice and contained within the bowel. Plus I got the air out here. So this is just showing you a pneumoperitoneum. This one in particular is due to a perforation in the gastric body, but can't tell that. What's this thing here?
Cyst on the kidney.
Right? What organ is this?
Kidney.
Kidney. Cyst. Right? So how do I know that? Well, now I know that's the kidney. Hey, just out of curiosity, right or left kidney? Right kidney. Right kidney. Remember, opposites. Opposites, okay? Your left is their right. So right kidney, and then I have this growth kind of off the kidney. I can see it. It's like cutting into it here. It's attached to it. And then the key thing on that is it highlighted with contrast? It is not, which means it is likely a fluid-filled cyst. If this was a carcinoma, it would be highlighted with contrast because cancers need blood, right? And so that's a nice part about these CTs with contrast is I can tell you that, yeah, that's a renal cyst on the right kidney. What's this? That's the aorta. It's not the esophagus. What's this? What side of the body is this on? So what is this? Liver. Right? Remember, liver normally goes down past the 12th rib. It's normally down there by the kidneys. And if you were like, hey, is that spleen or not? Well, what side of the body is it on? Cool. This is just another picture of a small bowel obstruction showing you, this is upright, it looks like I got cut off, showing you all of the air fluid levels going on in the small bowel obstruction. And that's all I have on that one. Questions? Come back at 5 after, we'll jump into the last slide deck.
All depends how early. I don't know, maybe that's stuff might change if it's all hands on deck.
Large, dilated. Also good knowing that everybody else is
Well, that's too big of a question. So correct, you can't you focus on just your just as a problem. So if I have
the tomatoes, spice. I wanted to say
that picture, with more
They're probably gonna explain. What's happening down there? They're doing that today. Today? Wait, did you guys see the There is. They should always have Did I
Right? Because the most common cause of fluid is
No, you said if it was close, he would go past, but because of the down, he's not going to have it.
Otherwise, the theme was building our.
That's when you have like your groupies on it.
Yeah, man, go.
We're interested in
We're
you.
in bad segments, we don't know where to have.
What? Come on, cuz.
Oh, Levi. I want my favorite.
What?
I found the picture. The thing, yeah. Oh, I tried to show you, yeah.
Tried my, have you tried the kimchi yet?
I had.
Not as spicy.
No, because I understand the one that you, because you know, like, some of the ones are like, sweet peppers, sweet red peppers. I think the one they use is like the bell pepper, the one that I use. No, I don't use that.
Well, now you know, next time you make it, put it in the hot. See how it change.
Yeah. No, but look, I can add something.
No. Say again?
I can add something.
I came in, I've been trying to go through. This season, last game I was receiving. Which one did they put on here? I thought it was I thought that would be some drugs. You just don't. I know that it's yeah, I bet. There wasn't any wasn't a very absent one. I couldn't remember. One of them is like straight up and down. Except for the side of the
Air Force always has one slide and two slides. So that's all. Alright, let's take our seats, let's get back into it again. Let's get back into it. Last slide deck. Woo! We're gonna be done with it today. Woo! No? Okay. Fine. What? Maybe, I don't know, not too, one slide show, right? But when we get down towards the end, if you looked at it, you may not have, it goes pretty quick towards the end, kind of like that first block. Because it's like, here's a uterus, here's our study. Here's a bladder, here's our study. Here's a urethra, here's our study. We just kind of roll through it like that, so it goes pretty quick down towards the end. Neuroperitoneum on this one again, okay? Some more small intestine, large intestine, spleen, liver, pancreas, gallbladder. Ooh. Okay. Small intestine anatomy. We've already kind of belabored this with the ileus and the obstruction. So if we get to those slides, I'm going to point out a few things and move on, right? If you have questions, raise your hand. Happy to slow down, right? I don't want to waste your time because of how much time we spent belaboring that, kind of like the first block. When we got to that upper and lower extremity, I was like, hey, we looked at this scaphoid already. Here we are again, right? Okay. We're going to look at ulceration, perforation, dilation, narrowing, obstruction. All the same things in the GI tract that we looked at the other two, okay? All right, so in general, opacification and distension of the bowel lumen is necessary for proper eval, no matter what modality is used. No matter whether we use an x-ray or whether we use a CT or whatever we're going to use, if the bowel isn't appropriately distended, not dilated, right? Not dilated, distended, right? I'm not going to be able to see what's going on in there, okay? What are some important findings? Well, when we do some of these things, and we do some of these CTs or even x-rays, we can see thickening of the bowel wall. Look at how thick the bowel wall is. Remember before we were looking, we were like, oh look, we see these thin little lines kind of coming across. But now look at how thick this is. Right? So that should stand out when you start looking at more of these normals, the thickening of the bowel wall. If you get into the CT, look at my ascending colon. Look at the dark gray. That's my bowel wall. The white is the contrast that they drink. Okay? Look at the contrast. Look at how thick the bowel wall is. You're going to see something that's called thumbprint sign. We're going to take a look at that here in a minute. Right? So that's going to be like your inflammation of the bowel wall. So your colitis, you can see it's all inflamed. I got infection or inflammation of the colon. That's going to be your colitis. Another thing you're going to see, right, use your imagination at first when you have these issues, is all of these extra kind of little lines in that dark gray radiolucent area. So you see all these kind of like radioopaque lines, not necessarily the ones off the vessels, right? That's my vasculature. But look at the ones kind of in that dark gray extraperitoneal fat area. That's what's called stranding, fat stranding, okay? What that is inflammation. They are hazy, strand-like lines around an organ that might be inflamed. You can kind of see it around here too. See some of it in here, in between these organs. That is a sign of inflammation. You'll see it commonly around the pancreas when the pancreas is inflamed. We'll look at some more pictures of that kind of as we go on. You can see it here. See this stranding there on the descending colon area. Let me erase it and draw it again. Kind of in this area here, a little bit up here. You see what's called fat stranding, that hazy linear appearance, typically surrounded by more radiolucent, darker gray appearance, right? Because that's going to be your fat, your visceral abdominal fat area, okay? And you're going to have those little stranding areas because of the inflammation. All right. This is what I was talking about, that small bowel follow-through in that one picture of the stomach we had, how much contrast was in there, right? This is the final picture, okay? What the actual study looks like is they take a picture here, and they take a picture like every 30 minutes and watch the contrast march out through the small bowel. And they're looking at all of those pictures. Because this bright white was bright white more up here approximately in the beginning. And then as the barium goes through, right, we get a little bit thinner up here because it's being pushed through, it's being peristalsed through. And so this is the final picture of a small bowel follow-through. And how much information am I getting out of this, right? Not a ton by itself. It's kind of hard to evaluate what's going on, which is why there's multiple pictures as they march through this. These studies take like 4 to 6 hours because the patient just has to lay there and they just take more pictures all the way up until the contrast gets to the ileocecal valve and starts to go into that ascending colon. Then the study is done. So that's a small bowel follow-through. That's kind of what the contrast small bowel study looks like from an X-ray standpoint. Another reason we like CT, because look at all the extra detail I can get. You look large bowel, it's the same concept. Look at all the extra detail I can get when I do a CT. Okay? All right. Perforation, guys. The intestine can perforate, it causes duoperitoneum. We good there? Questions on that? Okay. There it is right there. Dilation, we talked about this with the obstructions in the ileus, right? When the bowel dilates, it gets wider than normal. How do I know this is small bowel? Look at that, I got my valvular conventes all coming across there. Okay, supine, so no air fluid levels. So it's a dilation due to a small bowel obstruction. Can you tell me it's a small bowel obstruction with just this fill if I didn't give you more information? No, because I got stuff cut off here, right? Where's my large bowel? What's going on? I don't know. But right now, I just have small bowel there. If I had the whole x-ray and you didn't see any dilation in the large intestine and you saw all the air kind of missing from the rectosigmoid area, then you can confidently say it's a small bowel issue because if it was a large bowel issue, the large bowel is going to be affected as well, and that's going to be dilated. But this image is kind of cut off. So here we go. This is the one between the two, right? I've already said it, but now I got another slide for you. Small bowel obstruction, post-surgical adhesions, most common. Ileus, last 48 hours abdominal surgery. Months, days. Patient history, key discriminator. If in clinic you're unsure, don't know the truth. Send them to the CT scanner. That'll be your study of choice if you're unsure, okay? But you can make a pretty good idea here. Effusions take months to years to develop complications. I've never seen one that's been years, but it's absolutely possible. I've seen two small bowel obstructions, okay? They were both between that like 5 and 10 month range. But it still can be longer than that. The key thing here is usually the ileus, probably still in the hospital because you're probably just in your post-op care, maybe right after you got sent home, depending what kind of surgery it is, right? I think when I had my hernia repair, which is an abdominal surgery, right? That was outpatient. Went in, had my hernia repair, went home, actually came back here, took my test on Monday. Terrible. Don't recommend. Take your time. Anyways, so that right there distinguishes between those two. Another obstruction, showing the upright film, the multiple air fluid levels, that parachute sign, what we looked at in the last slideshow. Okay? If you have questions about those two things, let me know. Crohn's disease. Now we have finally another slide with the disease and information. Okay. Right? So these are the diseases that are important to know. Fever, weight loss, fatigue, nausea, anorexia, abdominal pain, that's like everything. Okay. Oh look, 85% diarrhea. Okay, so now diarrhea is going to help you start thinking possible Crohn's disease. Rectal bleeding, probably not. But rectal bleeding or blood in the stool can help me distinguish between ulcerative colitis or Crohn's disease. Crohn's disease usually is non-bloody diarrhea. Usually. Ulcerative colitis usually has bloody diarrhea. Okay? Why? Because if it's ulcerated, it's going to be bleeding. Crohn's disease is just the inflammation. We haven't started ulcerating and bleeding yet. Alright? So, CT with contrast is the study of choice. Right there in blue for you. Sure, you can do a small bowel follicle like we saw, but it has low test sensitivity. But the key things you're going to find on the imaging, if you do x-rays, CTs really, is going to be narrowing with ulceration of the terminal ileum. String sign, we're going to look at. String sign is where you're going to focus on for Crohn's disease. This is the string sign, okay? So, this is all small bowel. Can you see how you can tell just by, I know it's cut off, but looking at this, that that's small bowel and not large bowel, right? Got lots of different loops kind of coming all over the place. That is small bowel. What happens when we get here is we're going down into the terminal ileum and we get this string sign. Why is it like that? Because the walls of the small bowel are so inflamed from the Crohn's disease, it's creating a narrow pathway for that contrast to come through. It looks like a piece of string. On top of that, it's in the ileum. So what are we going towards? The ileocecal valve, right? Where is that typically? That's typically in the lower right side in this area, and that's where the string sign is. Is that always a guarantee? No, not necessarily. Can you get a string sign somewhere else? Yes, you can, right? But it's just other clues that kind of try to help you out. Going back to this CT picture, and again, I know it's large intestine, but you can see what I'm talking about. The concept is still here. The walls of the intestine get so inflamed that it compresses things in general, and that's what's causing the string sign for your Crohn's disease. Okay? Does that follow? Does that pathophysiology make sense? I know you haven't had GI yet, so I'm trying to find a way to kind of give you the foundation so you understand what's going on. That's it. Besides obstruction in ileus, Crohn's disease for the small bowel. Okay. Large bowel. A couple of different things. So, this is a double contrasted study. This is barium and air. Okay. Sorry. All right. It says barium and air. So what happens is they put it up here into the rectum, they blow the balloon up, and then they pour the contrast in, and then afterwards they pump air up to kind of give two contrasts. They call it double contrast to help really see the large intestine well. And so what we have here is our ascending colon, right? Transverse colon, descending colon, rectosigmoid. Rectosigmoid, ascending, transverse, descending. Okay? Got your splenic and your hepatic flexures in there, and it gives a good visualization. So nice smooth walls. You can kind of see the haustra coming in here. I don't see any outpouching. This is a normal study. Ulcerations, ulcerative colitis now, right? So there are Crohn's disease, small intestine, inflamed, string sign, ulcerative colitis, might have bloody diarrhea. And what you're looking at again, look at my smoothness here of my walls of my large intestine. And now look at kind of like the polka dotty kind of inflamed area there for the ulcerative colitis. Okay? So that's what's kind of showing you there. That bloody diarrhea will help you determine that along with the image. Pneumoperitoneum again on a CT scan due to perforation. Large bowel can still perforate, usually from diverticula that perforate, but any perforation in the abdomen can cause that pneumoperitoneum. Dilation, talked about it already through the obstructions. Okay, this particular one is due to renal hernia. I can't tell that by the picture. I know that by the image, but then if I gave you a patient history of having, groin pain and give you all the stuff to rule out cancers and stuff like that, you'd be like, what are you concerned about? But again, know that for obstruction, which can cause dilation, your colon cancer is your most common, which is going into this. Again, so patient standing, but don't get confused with that being an air fluid level, because that's your descending colon. The large intestine doesn't have air fluid levels. That's your transition point. That's your transition point. There's your obstruction. Okay? And look, we're starting to affect my small intestine here. See the difference here? See the valvular conaventes and the way the loops come across? Same thing here, another loop coming across. Valvular conaventes and some air fluid levels. So these are air fluid levels. This is your transition point from your obstruction. Everything proximal to it, starting to dilate. Distal is collapsing, still a little bit of rectosigmoid air. But this would be your large bowel obstruction causing dilation. Narrowing is just that, narrowing. Okay? So you know about how large the large bowel should be, the descending colon should be coming down, and it's not that large. I have narrowing. Why do I have the narrowing? I don't know yet. This is just describing what narrowing looks like. So you can see what narrowing is when it comes to the large intestine. Colon cancer, most common cancer of the GI tract. Mostly occurs in the rectosigmoid, mostly. Doesn't mean it can't be in the ascending. Doesn't mean it can't be in the descending or the transverse, mostly. What are your risk factors? Polyps, history of ulcerative colitis, Crohn's, family history, prior pelvic irradiation, sure, but we're talking immense amount of radiation, right? Multiple CTs, weekly, done for long periods of time. Pelvic x-ray is not going to cause colon cancer, right? So it's there because technically prior pelvic radiation, if you get enough of it, it can cause a cancer, but it would require a lot, right? So what do we normally find? We end up finding a large polypoid filling defect. We'll take a look at what that looks like. The apple core lesion, that is going to be your key thing that we're talking about, okay? Frank perforation, that means I got a neuroperitoneum in there. Large bowel obstruction, most common cause of large bowel obstruction is cancer. Okay. Where does it metastasize to? Usually liver and lungs. So if you find a colon cancer, that's the next place you're looking to, because let's figure out if it's metastasized or not yet. If you don't get their screenings, they don't get their colonoscopies, they're not doing what they need to do, usually it's another one. By the time we find it, we're in stage 3 or stage 4. And do not, I know you're going to get the GI, and they're going to talk about the ages and the risk factors of colon cancer. Do not let age stop you from doing the workup. Okay? Yeah, we don't get colonoscopies till 45. Guess what? When I came through this program, it was 50. They dropped it to 45 because the incidence of colon cancer is increasing in the United States significantly. They're already in talks of dropping that screening from 45 down to 40. They're already in talks, which means, like me, some of you in here, get ready. But it's super important. If you think they have the symptoms, do it. I had a classmate of mine who came through here in phase 1, was dealing with GI issues. Went in, he was young, doing his thing, completely overlooked the fact that it could have been colon cancer, even though some of the symptoms were kind of like, no, you're too young, you got no family history, it's not a big deal. Everybody's always patient zero, right? They found out he had colon cancer. He took a break from the program, went in for treatment, got better, came back to the program, finished phase 1, went to phase 2 at BAMC to continue his treatment, do the program, had to step out again because he had a recurrence, he came back, it metastasized, he ended up passing away about a year and a half after a diagnosis, because by the time they found it, he was already stage 3, bordering on stage 4, right? 31 years old, I think, when he was coming through the program. So, if you think it's a colon cancer, just do the dang colonoscopy and find out, right? Don't let age be a discriminating factor for you. All right, but here's that apple core lesion. It looks like an apple after you've eaten it all, right? That's why they call it that. Apple core lesion comes around, does this. Okay? What do you notice about the location of this apple core lesion? It's right past the ileocecal valve, and it's in the ascending colon. It is not in the descending colon or the rectosigmoid colon, which is the most common place for colon cancer, because it can be other places. But do you see how this looks different than the string sign? This is different than the string sign because it's on the large intestine, it's on the ascending colon, it is not on the terminal ileum, and even where it's narrowed because of the apple core lesion and the cancer being, this is all cancer, you just can't tell on the x-ray, even where it's narrowed, it's not like that thin piece of string, right? It's a little bit thicker, it's got the apple core. This is going to be your sign between the two things in turn between Crohn's and colon cancer. Question? Here? Maybe. That's something that I want more look at. Why does it look like that? I don't have an answer for you. But if I were to get this x-ray, guess where they're going next, guys? CT. CT. I'm throwing them on the scanner because I want more details of how large this lesion is, where it's at, and what the heck is going on up here in the upper right-hand corner. They're eventually probably going to get a colonoscopy as well, right, to really look on the inside to see where is all of the cancer, how bad is it. But if I catch this on imaging, I'm getting a CT next because I want more information about that right upper quadrant area here of what the heck that is and why does it look like that. And look at that apple core lesion. It's not in the descending colon. All right, diverticulosis. Outpouching, right? Diverticuli is what they're called. Diverticulosis is the medical term for a patient who has diverticuli. Diverticulitis is when it's inflamed and angry and causing symptoms. Make sense? You can have a patient with diverticulosis. It doesn't become diverticulitis until they start having pain and inflammation and start having symptoms. Okay? It is common to get them as we get older. You get these outpouches. It's completely normal to have. It is very, very common. Usually it's asymptomatic. Look at that. The most common cause of massive lower GI bleed. When these things get inflamed and angry, they bleed. And they bleed quite a bit. And so a lot of times these are what's causing it. So usually in the sigmoid colon, and when it becomes inflamed or bleeds, it's diverticulitis. It's one of the few conditions that once it's been treated, we'll get into this here, nosis versus itis, but it's one of the few conditions that once it's been treated, this pain is very similar. Patients know what this feels like. Patients who have bouts of diverticulitis know, right? And so they've had a couple of rounds of diverticulitis, and they're coming in and they're seeing you, and they're like, hey, I'm in pain right now. It feels like my diverticulitis. Okay, does it feel exactly the same, like just like the last time? Yeah, it does. Great. I'm not imaging, right? If I have evidence already from prior episodes of diverticulitis, it's in their medical chart. They've got the image to prove it. They've been treated for it. And the patient walks in and they're like, it's happening again. I can feel it. I know it. Like, this is exactly what it feels like. I treat them and I send them, right? There's no reason to continue to image somebody who knows what this feels like. because it's pretty specific in that aspect. Now, if they have a history of diverticuli or diverticulosis, and they've never had an episode of diverticulitis in their charts, and it's their first one, you need to make sure that's what's going on, and that one requires imaging. So just trying to save your patient's radiation in the future, right? You can treat based off of symptoms in somebody who's got a history of this stuff. All right. Most of the time, unless it's inflamed, it's asymptomatic, like we talked about. You see the outpouchings. CT with contrast is your study of choice to truly evaluate it when you're looking for the itis. You need the CT with contrast to look for the diverticulitis, because what you're looking for is that fat stranding, that inflammation, that thing we just talked about in the darker gray area, the highlights, the more radiopaque lines, that inflammation and fat stranding. That's what you're looking for to help diagnose diverticulitis. You can't see that on x-ray. If you continue to get the barium enema on the x-rays for the initial study, you're just going to see the outpouching. You're not going to see the inflammation. So that's why CT with contrast is your study of choice. You see that fat stranding and that bowel wall thickening. Here's an example of that. All right, I got my little air-filled areas. That's my outpouching, my diverticuli. And then look at my dark gray area in an area that's not inflamed, right? An area that's not inflamed and angry. And then look at this. This should all be just like this, but it's not. I have that fat stranding, that inflammation sitting in that area. That's what we're looking for. And look at how thick the bowel looks. Right? I barely have any opening there. I barely have any pathway on my CT. It's just all tissue. Because it's just fat, it's angry, it's thickened. Okay? All right. Appendicitis. Right lower quadrant pain, okay? Usually caused by an obstruction, appendicolith. Maybe it's calcified, maybe it's not. CT or ultrasound modalities of choice. Okay? CT or ultrasound are the modalities of choice. When am I doing an ultrasound? Pregnant women and peds. Pregnant women and peds. I like your thought process with unstable. Probably not going to work with this because you're not doing this. The ultrasound tech's going to do it. But pregnant women and peds. What's better, CT or ultrasound to diagnose appendicitis? CT. Absolutely, it's better. Right? Look at my big fat appendix sitting right there. Look at my big fat appendix. Absolutely, it's better. But if I'm saving radiation and I can diagnose with an ultrasound, pregnant women and peds, when would I use an MRI? Not often. Pregnant women, if I'm concerned of appendicitis and my ultrasound is inconclusive, then I might get an MRI. Because it's not worth it for me. I CT in the baby, like that's a lot of radiation in that area if I can avoid it, right? I can get around, we talk about PEs, doing a CT on a patient that's pregnant if I can't figure it out. Because of the PE and we go through that algorithm, right, when we get there and the VQ scan was unconclusive, whatever, I can get to that because I can shield the stomach and try to prevent some of that radiation from getting to baby, right? And in reality, the PE can kill mom, and if you kill mom, the baby's not going to survive. But I can't protect baby by doing a CT for the appendix. There's no way to protect baby. So you might jump to an MRI if you absolutely need to. Super rare to do still. Right? You guys need to focus on CT and ultrasound, and the answer between which one do we do for the study of choice is in the demographics. Are they are they pregnant, and are they a pediatric? If they are, we do the ultrasound. Okay? FYI slides, we'll go through them pretty quick. Talking about polyps, they get older, polyps are inside, diverticuli are outside pouches. Polyps for the intestines are inside pouches. We'll see what those look like. This is just telling you the risk of those things turning into cancer based off of their size. Okay. These are what polyps look like. Do not memorize sessile or pedunculated. I'm just showing you. Notice how the polyp is on the inside of the intestines. The polyp is going on the inside. All of my diverticuli are out pouches. This is inside. Okay? This is what they'll find on colonoscopies. It's not a very minimum, but they'll go in there, take them out, grade them, stage 1, stage 2, what's going on, how often do you need a colonoscopy. The nice part about colonoscopies is they can remove those when they see them. So, Know that polyps go on the inside, diverticuli go on the outside. Okay. Which is the bowel where the issue is stemming from on the left picture? Small. What about the right picture? Large. Is there small bowel involvement on the right picture? Maybe. Does it matter? No, because there's large bowel involvement, so I know the problem is in the large bowel. Doesn't matter if there's small bowel in there or not. So if you get a picture that shows large bowel clearly, and you're like, gosh, is there small bowel involved? Is that? I can't really tell. Don't spend your time diving deep and trying to figure it out because it doesn't matter. Because the problem is always in the distalmost location. So if it's like this, then it's a large bowel problem. What do we call that based off of the things we looked at? No, not that. Yeah, ulcerations. Ulcerations all throughout here. Probably ulcerative colitis, to be honest with you. That's probably what that is. But yeah, ulcerations. Questions on the bowel again? No. Okay. Spleen. There it is. Which one's the spleen? B. Spleen. Liver. You can't choose C. It's not there. Spleen and liver, right? They look the same. But boy, on this image, you can definitely tell me which one's liver, which one's a spleen if you know your anatomy. Okay. Cool. We covered it. Spleen should not project past the 12th rib. If the spleen projects past the 12th rib, it is splenomegaly. What would cause it? Top of your differential, probably mono, right? There could be other things. And what? Probably mono, right? Past the 12th rib, splenomegaly. X-ray or CT will be able to find it. This here is a contrasted CT. And what you have here is the main spleen in the center. And then surrounding it is blood that is coming out. So this is a splenic rupture. And so remember how we talked about how the main organ is going to be a little more highlighted than the surrounding fluid and tissue when you end up having that rupture, kind of like that dissection, right? We have that nice bright white area, and then we had that extra area that we're like, oh, I can kind of see that. That's weird. That was the blood kind of leaking into that other layer. Same concept here. We got blood leaking out around the spleen. And so this is a splenic rupture. And you can see, there's my 12th rib. There's my 12th rib right there. So this was splenomegaly that led to a splenic rupture. Here on X-ray, the white arrows show you the spleen edges. The black arrow shows you the 12th rib. That's it for the spleen. Know how to signify whether or not it's large, know where it's at, right? About it. Liver, there it is. Normal study, this is your CT. I also got it labeled for you. Know what normal looks like. So that way when you get this, you know it's not normal. What's wrong with this liver? No idea. Probably cancerous because these aren't like the cyst that we saw on the renal cyst, right? Where it was a clear kind of radiolucent fluid, kind of highlighted all up in here. So probably hepatic carcinomas, but I don't know. Biopsy will tell me that answer. You'll learn that in GI. But what I need you to know is this is what a normal liver looks like, and this is what an abnormal hepatomegaly looks like. Okay? That's it for the liver. No hepatomegaly, no splenomegaly. Remember for your clinic that a Rydell lobe is a normal variant. You don't know it's a Rydell lobe until you do your further imaging to make sure, and you see the enlarged limb, okay? So know how to pull out splenomegaly and hepatomegaly, and know where they're at anatomy-wise. Gallbladder. Ultrasound. Study of choice for the gallbladder is ultrasound, okay? Here is my nice fluid-filled, what kind of fluid? Bile. It's still fluid. Gallbladder. This is the gallbladder. This is why we use it. There really is no tissue inside the gallbladder. So a CT is not super beneficial. I don't have really a whole lot of blood flow to it except for just taking care of the gallbladder wall. There's really not a whole lot inside of it except for bile, fluid. So ultrasound is better because ultrasound will be able to tell me when there is a stone that is causing posterior acoustic shadowing, and I have that mass sitting in there from my ultrasound because I should be seeing fluid only, but I don't, right? Murphy's sign is that physical exam find where you press right up, breathe in. You guys just did that on, some of you who had abdomen just did that on the Clin Skills test, right? That Murphy sign. Murphy sign does not tell you whether or not there's gallstones. Murphy sign tells you when the gallbladder is inflamed and angry. It is a physical exam test to test for cholecystitis. They can have gallstones and not be inflamed and angry, and you'll have a normal Murphy sign on physical exam, okay? But imaging is going to tell you whether or not there's gallstones or not, and that's going to be the right upper quadrant ultrasound. Sometimes you get that. Now, how in the heck, so it says sludge, right? So what that is basically we call it sludge, a technical term, right? It's thickened bile. It's thickened kind of inflamed bile, right? Which is why it shows up like this. But how the heck am I telling the difference between that and a hard mass? Aha, the posterior acoustic shadowing versus I still have my posterior acoustic enhancement here, right? Because it's still kind of like a liquid. It's just a little bit thicker, but it's not dense, it's not hard, it's not a mass, okay? And so sometimes you will get this in patients that are having episodes of cholecystitis. They're having some inflammation. It's the sludge is kind of agitating them a little bit, and you'll see that on the imaging. So know that the gallbladder typically is going to be ultrasound for your study of choice. And that is what I need you to know. Questions so far? I know we're going through these pretty quick, but it's literally just know one or two things, right, for this area. You'll learn more about them when you get to GI. Pancreas sits right by the liver. Sits right in that nice little duodenal area as well. Okay? CT for a pancreas. You will almost never see a pancreas on an x-ray unless what? We talked about it. Calcifications, right? Unless this thing is a nasty calcified pancreas due to chronic pancreatitis, probably potentially leading towards pancreatic cancer, you should almost never, ever, ever see it on a regular x-ray. CT, you will see it. It is the spongy looking tail-like thing in the middle of the abdomen. And I will tell you right now, this is one of the best pictures you will ever see of a pancreas on a CT, so enjoy it. Okay? There it is. One of the best. They can be really hard to see. Almost impossible even on a CT without contrast, because there's so much that's going on in the abdomen. The contrast really kind of helps pop it out just a little bit. Pancreatitis is a clinical diagnosis, much like our pneumothorax, okay? You will have some CT findings if you're going to image it. CT is your study of choice. Look at all my fat stranding again. Remember we talked about that inflammation in that fat stranding area. But these patients are going to come with epigastric pain, intense epigastric pain. There's not very many things that are like right in that area, okay? And so you're going to end up getting the CT. You're going to end up seeing this fat stranding on here all around where the pancreas is. So for those of you that are wondering, this is the pancreas. Right? Like I said, that last picture is the best one you'll ever see, so enjoy it. They can be hard to find, especially when there's all this inflammation going on. Now, if you have the CT, you can scroll it out. It'd be a little bit easier to pull out, right? But then here I got my chronic pancreatitis. You got all those calcifications sitting in there from the chronic pancreatitis. Might get some pseudocysts, okay, which I think, yep. So pseudocysts sitting off the top here, okay. Might get some of those. Here's another pancreas. It's calcified. It's got a pseudocyst on it from chronic pancreatitis. Have an idea of where it's at. It's always in the central area of the abdomen. It can be hard to see. The CT is going to be your study of choice for pancreas issues. There's another one. This one here is the pancreas is all this. And then this here is a pancreatic head tumor. Okay, erase it. Yes, I know it's more radiolucid than the rest of it. So you're like, why is that a tumor? It's a tumor because they found it, they did a biopsy, and they confirmed it was a tumor. There's nothing on imaging for you to go, that's a tumor. Because that could be a pseudocyst. I don't know, right? You see it on CT, now you you order a biopsy to confirm what it is. I need you to know that the pancreas is done by CT. I need you to know that that's your study of choice in that aspect. Pancreatitis is what you're looking for. Watch for that fat stranding. Sometimes that'll help you kind of find it. That's really all I need you to know for the pancreas. What's this condition? Splenomegaly. Good stuff. Yellow arrow sign, but still coming down fast. It's well through. Okay. Ooh, what the heck is going on here? Gallstones, right? It's the only one I gave you an ultrasound on. They're not nice and round like the one we saw, but I got my posterior acoustic shadowing there. And so that tells me that there's gallstones there. Polyps, diverticuli. Inside, outside. Got it? See it? Magic? Questions on GI stuff on those organs? I said this one was pretty quick because it's just showing it to you again. We covered it already, but we were looking at it, just kind of rehashing it and adding a few things. GU stuff. We're running out of organs, folks. We're almost there. We are running out of organs. Urinary tract. There it is. Isn't that lovely? Remember that the urinary tract is more than just the bladder and the urethra. It is ureters and kidneys as well. Right? Ureters and kidneys as well. Technically, kidneys are part of the genital urinary system. We may discuss them a little bit in GI, but they're really GU. Okay. Intravenous pyelogram. Now, I heard in pathology we talked about pyelograms a little bit. Yes, no, not yet? Like one slide? Yeah. We don't really do these anymore, okay? Why do I show it to you? An IVP is basically a study looking for ureteral stones, looking for kidney stones and ureteral stones, or some hydronephrosis, that kind of thing. What it basically is we give the IV contrast, and they take a bunch of regular x-ray pictures. And the goal for the x-ray tech is to catch the contrast in the calyces, all the way to the ureters down to the bladder. Because what I'm looking for is an obstructing stone. Because if all of a sudden I don't have any contrast, like right here, going down into the bladder on this side, I have a stone in there that's obstructing. Can I see the stone? No. But by watching the contrast flow, I can tell you if there's a stone or not. Now here's the catch. How nice and straight are ureters? They're not. They're super torturous, right? So patients gotta roll around, they gotta take a bunch of pictures, you gotta kind of piece them together. Because of that, we don't really do it anymore. We just do a CT scan, all right, to look for kidney stones and we can measure the stone. However, I teach it to you and show it to you because you need to know it exists and you need to know what a pyelogram is because there is a possibility you could be deployed somewhere that doesn't have a CT scanner. So if you don't have a scanner, how are you going to evaluate for the kidney stone to see if it's obstructing or not? Because the difference in somebody who has an obstructing stone and a non-obstructing stone out in the field is the difference between somebody who actually has to leave and go and get that taken care of versus somebody who's just got to pass it. It's going to suck, it's going to be painful, but they can just pass it on their own. How do you find that? You need an IVP if you don't have a CT scanner. For those of you that are Guard Reserve and you're going on the civilian sector, you're probably never going to do this unless you're in a deployed setting and you don't have a CT scanner. Okay? Because now we just order CTs. And here's why. They're wonderful. We can see them. So remember, nephrolithiasis is when the stone is sitting in the kidney. Urinolithiasis is when the stone is in the ureter. And here's when you have both. Right? CT scan with or without contrast? What do you think? Without. Look at my stones. Look at how bright white they are. What color is contrast? Bright white. Right? So if I fill this ureter with contrast, I can't see my stone. Right? This is a non-contrast study. Typically a prone CT because it allows the kidneys to be better visualized because the kidneys are retroperitoneal. Right? So if I have them up more, I can get a better picture of them. So it's going to be a prone CT, non-contrast. Non-contrast. Here's one of those IVPs, and give me a second. I'm going to text Major Villalobos and see if he's still good with what we talked about, because we will not need more than 30 minutes. Hang on. What happened?
They told us that all of us have to be in Biloxi at noon.
Oh, I forgot about that. Thank you.
I mean, we could be late, I don't know what's.
No, we can't be late. No, we cannot be late. What that means is, the good news on that is we won't have very much this afternoon. We will not be staying till 5 today. That I can guarantee you. We might not even stay till 4, but we definitely won't be staying till 5. Alright? Alright, so real quick, let's get through 1 or 2 more slides so we can get down to bless you real quick. Alright, so here's a normal IVP, right? Normal. I got my calyces going down into my kidneys, or into my ureters. Yeah, words. Into my ureters. This is what can happen when you have an obstructing stone. Notice how on the right kidney, I have a dilated calyces here. Look at all this contrast in here. I can't really see the ureter coming down, and I'm backing up. I'm causing hydronephrosis in this right renal pelvis and the calyces. So what's happening is that stone is stopping the flow of urine and contrast, and it's backing up. This is where these IVPs can really come into play. So if you get somebody who's having the pain, you're like, yeah, no, you're not having hydronephrosis yet, you're out in the field. All right, here's some meds, it's gonna suck, but we can kind of push through this. You get this, they probably need to leave, because that's not gonna fix itself on its own. They need to at least get somewhere that can take care of this and break that stone up. And that's where this IVP comes into play. And because this gets into when do we order an ultrasound, this is where we'll stop. So we have about 30 slides left. Some of those are review, and a lot of those are, like I said, this is a ureter, here's what you do. This is a bladder, here's what you do. So it will go pretty quick. Will not stay till 5, likely be done before 4, okay? So let's all get on the blessing and get yelled at, I don't know.